Welcome to The Explainer. Today we are jumping straight into the absolute center of the human GI tract to decode the incredible mechanics of the small bowel. We're going to investigate some truly bizarre clinical blockages and explore the brilliant surgical actions required to fix them. So whether you're reviewing these concepts or seeing them for the first time, get ready. We are breaking down some really complex pathophysiology into clear, visual takeaways. Let's get started.
Okay, let's dive right into this. Think of your small intestine as a high-speed, perfectly balanced transit system. But what actually happens when that system faces unexpected, sometimes totally bizarre blockages? We're not just talking about your standard post-op adhesions here. No, we're talking about massive gallstones escaping their usual anatomy, or calcified plant fibers bringing digestion to a screeching halt. Today, we're decoding these high-stakes scenarios.
Here is our clinical syllabus for today. First, managing complex bowel obstructions. Second, the terminal ileum and malabsorption. Third, uncommon intraluminal bowel blockages. And finally, gut anatomy and secretory physiology.
Let's start with Section 1, Managing Complex Bowel Obstructions, focusing specifically on the hidden dangers of chronic radiation enteritis.
All right, here's our first clinical puzzle. Imagine a 42-year-old female patient presenting with persistent, low-grade small bowel obstruction symptoms. She actually has a history of high-dose pelvic radiation therapy from about 18 months ago. When we see a timeline like this, months or even years down the line, we really have to ask ourselves, what is the primary underlying pathophysiology here? What exactly is happening to that irradiated tissue so long after the radiation has stopped?
Well, the core issue here is a process called obliterative endarteritis. You see, we aren't just looking at the acute sloughing off of the mucosal layer. That happens early on. Chronic radiation enteritis is this progressive, totally irreversible condition where the microvascular beds inside the intestinal wall essentially choke off. This chronic ischemic state leads to dense collagen deposition, profound submucosal fibrosis, and a huge propensity for thick, woody adhesions and strictures. The bowel literally loses its motility and becomes rigidly locked in place.
And this is exactly why the surgical approach here is a matter of life and death. If you go in and attempt forceful, wide lysis of these adhesions, like trying to manually tear them apart, you are heading straight for a disaster. These irradiated tissues are ischemic and incredibly friable. Tearing them frequently creates multiple holes or enterotomies that simply will not heal, which leads to catastrophic leaks. Instead, the preferred surgical action is either a highly focused segmental resection of the stricture or just bypassing that hostile area entirely with a side-to-side surgical bypass, using non-irradiated, healthy bowel.
Moving right along to Section 2, Terminal ileum and malabsorption, bile acids, bacteria, and stones.
Now, what's really fascinating here is this single striking number, greater than 95%. That is the percentage of secreted bile salts actively reabsorbed by a healthy terminal ileum, so they can be recycled via the enterohepatic circulation. It's a tiny segment of anatomy, right? But it does some seriously heavy lifting. If a patient, say a 24-year-old medical student with Crohn's disease, loses function in this specific segment, that 95% reabsorption just plummets, and it triggers a massive cascade of metabolic failures.
Let's trace the downstream domino effect of losing that bile acid reabsorption. First, the gallbladder takes a hit. With bile acids lost in the stool, the systemic pool gets severely depleted. Hepatic bile becomes supersaturated with cholesterol, and without enough bile salts to keep it soluble, that cholesterol precipitates out, forming cholesterol gallstones. But the damage doesn't stop there, it hits the kidneys too. Unabsorbed dietary fats spill into the colon and aggressively bind to calcium. Normally, calcium binds to dietary oxalate so your body can excrete it. But with calcium stolen by those fats, the oxalate is left completely unbound. It gets rapidly absorbed by the colon and precipitates in the kidneys as calcium oxalate stones. Literally, one damaged intestinal segment ruins both the gallbladder and the kidneys.
And that leads us to another wild malabsorption phenomenon, blind loop syndrome. Imagine a surgical reconstruction leaves a limb of the small bowel completely excluded from normal peristaltic flow. You get stasis. This stagnant fluid becomes a breeding ground, causing massive small intestinal bacterial overgrowth, or SIBO. These bacteria just run rampant. They prematurely deconjugate those precious bile salts, which leads to severe fat malabsorption and weight loss. On top of that, the bacteria greedily consume available vitamin B12, ultimately culminating in megaloblastic anemia. It's basically a perfect storm driven entirely by a lack of mechanical movement in the gut. All right, on to Section 3. Uncommon intraluminal bowel blockages, intussusceptions, bezoars, and escaping stones.
Let's talk about intussusception. That's where a proximal segment of the bowel physically telescopes into an adjacent distal segment. Notice the sharp contrast between pediatric and adult cases here. In kids, this is usually idiopathic and can be pretty safely resolved with just pneumatic or hydrostatic pressure. But in adults, it's incredibly rare, and 80 to 90% of the time, it's driven by a structural pathologic lead point, like a polyp or even a malignancy. Because of this, the strict surgical rule for adults is primary formal resection without manual reduction. You absolutely never manually squeeze an adult intussusception because you risk embolizing venous tumor cells or rupturing ischemic bowel right into the peritoneum.
Or get this. Imagine a patient with a history of severe chronic constipation who develops an obstruction from a calcified mass. This is called a phytobezoar. It's a really dense concretion of poorly digested plant and vegetable fibers, like cellulose. We typically see this in patients who've had prior gastric surgeries, like a vagotomy, which actually impairs normal stomach acid production and grinding. Without that acid, the fibers just clump together, calcify, and migrate down to wedge perfectly in the narrow small bowel, usually right at the ileocecal valve.
Okay, test yourself on this multi-system clinical triad. A 72-year-old female shows up with a classic mechanical small bowel obstruction. Her scan shows a high-density calcified mass impacted right in her mid-ileum. But wait, she also has pneumobilia, meaning there is air visible inside her biliary tree. So think about this. How does an intestinal blockage physically connect to air in the gallbladder pathways?
The answer? Gallstone ileus. This is beautifully mapped out by the legendary Wrigler's triad. The pathophysiology here is just wild. A massive gallstone literally erodes directly through the wall of the gallbladder and right into the adjacent duodenum, creating a fistula. The stone then travels down the digestive tract until it gets wedged, causing a mechanical small bowel obstruction. Meanwhile, intestinal air travels back up through that newly formed fistula straight into the biliary tree, creating that pneumobilia. 3 very distinct findings pointing to one dramatic mechanical failure.
So, how do we actually fix it? Emergency enterolithotomy. The immediate priority is simply to relieve the blockage. The surgeon makes an incision, an enterotomy, but note step 2. It absolutely must be made in the healthy bowel proximal to the obstruction. You gently milk the stone backward into that healthy tissue, extract it, and then close the bowel transversely to keep the tube wide. And here's a massive clinical pearl view. In an elderly, unstable patient, you leave that gallbladder fistula strictly alone. Attempting a complex right upper quadrant dissection in a highly inflamed field like that just adds prohibitive, totally unnecessary risk.
Finally, Section 4, Gut Anatomy and Secretory Physiology. We're going down to the microscopic and molecular level to see exactly how the gut defends and regulates itself.
First up, let's establish our boundaries and triggers. Anatomically, the ligament of Treitz is this crucial fibromuscular band anchoring the duodenojejunal flexure, officially marking the transition from the upper to the lower GI tract. Chemically, the gut relies on these really elegant feedback loops, like the hormone secretin. When highly acidic gastric chyme, we're talking to pH under 4.5, enters the duodenum, S cells immediately release secretin right into the bloodstream. This signals the pancreas to pump out massive volumes of water and bicarbonate ions, rapidly neutralizing the acid and perfectly optimizing the pH for digestion.
And speaking of defense, look at these microscopic guardians, Paneth cells. Located exclusively deep within the crypts of Lieberkühn, they are the absolute front line of our innate mucosal immunity. They are packed with granules containing antimicrobial peptides like alpha-defensins, lysozyme, and phospholipase A2. By secreting these into the intestinal lumen, Paneth cells actively shape our gut microbiota and, most importantly, they protect the vulnerable host stem cells living at the base of the crypts from bacterial invasion. We've got time for one final, really striking clinical vignette. Imagine a 35-year-old female comes in with severe abdominal distension. During laparoscopy, the surgeon finds something pretty shocking. The visceral peritoneum and omentum are completely covered in multiple gelatinous mucinous tumor implants, just sitting in a large pool of mucinous fluid. What exactly defines this highly unusual jelly belly presentation?
This extreme syndrome is known as pseudomyxoma peritoneea, or PMP. It most commonly originates from a primary mucinous neoplasm of the appendix. When that appendix ruptures, it sheds mucin-secreting cells that aggressively seed the entire peritoneal cavity. Because of how completely it coats the abdominal surfaces, the standard treatment is incredibly aggressive. It requires complete cytoreductive surgery to physically remove the tumors, paired directly with HIPEC, hyperthermic intraperitoneal chemotherapy, to literally wash the abdomen with heated chemo and eradicate the microscopic disease.
And that brings us to the end of our explainer. We've seen just how delicately balanced the small bowel really is, from its microvascular networks that are so easily damaged by radiation, to its intricate pH-triggered hormones, to the physical limits that cause gallstones and bezoars to wedge tight. So I'll leave you with this provocative thought. As imaging and molecular diagnostics continue to advance, how can we better anticipate these catastrophic blockages and physiological chain reactions before they require the surgeon's blade? Keep questioning, keep learning, and thank you so much for joining me today.